Yes, Satyajit.
Yeah, so one of the things which I was noticing is in the last stage, when especially that is more prone to having a posterior capsule rupture. In your left hand when you were holding the chopper.
Chopper, yeah.
Yeah, so that is the time when I turned the chopper towards 90° and not keep it facing towards the posterior capsule when we are dealing with the last pieces. Because when you're doing on Centurion, it doesn't matter. But when you're doing on other lower end machines, there's a fear of surge, and that is the point where you can hurt the posterior capsule. So I always turn the chopper 90° so that even if it hurts the posterior capsule, it doesn't tear it. So what are your thoughts on that? Would you want to use a spatula in the end or something to be more careful? Subhash sir, we can't hear you.
Yeah.
Hello, can you hear? Yeah.
Yes.
Since the second case is almost ready, so we want the introduction slide of Dr. G. Ramamurthy. I know that sir doesn't need any introduction, but for those who are newcomers, they must know and they must emulate the great person, the great surgeon. He is internationally known. So let us have his introductory slide, and then the case description will be read by Sonali from here, and then we'll move ahead with the another case. We can have a lot of discussion. Don't worry, we are going to have full day. Okay.
I think one of the biggest achievements of Ramamurthy sir, out of the whole distinguished career that he has had, is now that Eye Foundation is shortly going to go public. So they have made so many centers throughout South India, and his son is working so hard in expanding, and sir himself, that it's already going to be in the public listing in a year's time. Eye Foundation, Coimbatore. Ramamurthy sir, already the audience is talking about investing in your company now.
Hello.
Yes, please go ahead.
A very good morning, everyone, and thank you so much for this kind invitation to be a part of this meeting. It's always a pleasure to be back in Patna, and the last thing I want to be told about me is what you just now said, Satyajit. I mean, I'm myself not sure about what's going to happen. There is talk about it, but let's see.
That's a big achievement, sir. 10 years back, you had done a live surgery in Bhagalpur, if you remember.
Yes,
that
yes,
was
yes.
Such a treat to see you.
So shall I share the details of the patient?
Yes, please, go ahead.
So it's a 57-year-old female, and she came to us with a diminution of vision since last 3 years. On examination, the visual acuity of the patient was hand movement, and the anterior segment finding was normal, but she had a mature senile cataract. Fundus was normal in this patient. Her steeper axis is 46.53 at 4°, and the platter axis is 44.27 at 94. Her astigmatism was around plus 2.26 at 4°, axial length 23.34, and hence the patient was planned for a trifocal toric lens, panoptic toric T6 series, and the incision is planned at 3°. Over to sir, the fellow eye of the patient is phakic.
Huh? ठीक है. What's the AC depth? Very good morning, everyone. Can you hear me?
Yes, sir.
Excellent. I am going to be operating on this very nice lady. She's around 60 years of age. She has a significant total cataract with a significant astigmatism. The plan is to place a panoptic toric intraocular lens. I'm using the Rivalia operating microscope. I have wonderful experience with that. And also the Centurion with the active sentry overlay. And I'll be implanting a panoptic toric. And she has a significant amount of astigmatism. So we are going to be using a T6 intraocular lens. I like to bend my own micro Rhexis, and I expect this to be an intumescent cataract because the AC depth was just 2.6 millimeter. I didn't see the patient on the slit lamp, but I think it should be, this may be saline jara par dijiye. Can I have the side put? Maji jara सीधा light पे देखिए, light देखिए, सीधा ऊपर देखिए. I like to have my side ports at around 70 degrees from my central port. Light देखिए. And this is the 1 millimeter side ports. Parakin hai. And I always inject because I am doing under topical and the lady is not too comfortable. I am going to even otherwise routinely I inject a little bit of parakin. Seedha light dekhiye. Maybe this is one of the few instances where a peribulbar or a anesthesia may be indicated because it's a live surgery and the lady is a little apprehensive with a total cataract. And let's see how we manage. And now I'm going to be injecting a trypan blue. Obviously this case requires staining. And I always inject add to that. I think normally in my place what I do is to make the side port incisions and then make the main port and then inject this trypan blue and air bubble main port 2.4. Ye wala. So that gives me some time for the dye to be in contact with the anterior capsule, and as you saw in the earlier case, get a beautiful staining of the capsule. And I have shifted, I was using 2.2 millimeters for quite some decades. But as was discussed earlier also, now I have shifted over to 2.4 millimeter saline. This saline. The simple reason being that it has been shown that the, see the light pe dekhiye, astigmatism induced by a temporal clear corneal well-made 2.4 millimeter incision is just the same as what is induced by a 2.2 millimeter incision. And when I have a 2.4 millimeter incision, I find that I have a excellent, there is no stretching of the wound, there is no damage to the wound, side port, Sinski hook. There is, whether during the introduction of the intraocular lenses or whether introduction of the phaco probe, get a very clear entry. And if the final size of the wound remains the same as what you started out with, that has the best stigmatic impact. I have kept it at 5.8 millimeter because my idea is to run the Rhexis within this. I've used disco whisk, and that with the combination of the sodium hyaluronate tends to flatten out the anterior chamber. And the idea is that 5.8 millimeter, I want a 5.5 millimeter Rhexis. And I'm going to try to run this within the confines of this Varion digital overlay that we have. As you can see, it's quite an intumescent cataract for 2 ml syringe, saline ke saath. So you can see that fluffy material coming out in spite of the high molecular weight viscoelastic. So I'm going to remove that.
Sir, in these kind of cataracts where there is also a fear of it being intumescent and the Rhexis running away, would you not want to just do it with the side port rather than making a main incision which is wider? There will be more viscoelastic leakage, and then just doing it with a small side port, completing the Rhexis and then making the main port?
No, excellent point, Satyajit. But as you can see, I am not using the main port for making my Rhexis at all. My Rhexis is entirely made through the side port. I am stabilizing through one side port with a Sensky hook because the patient is a topical and moving the eye quite a bit, and I am going through the side port. Micro Rhexis forceps here. So there is a tendency for it to run off.
So this is a very important take-home message. One must realize when you have to shift from a cystotome to a Uttarata forceps. Even with a very, very experienced surgeon like Sir himself, he has decided to move to Uttarata, and that is the best thing to be doing.
I'm using a micro Rhexis forceps, and I'm actually much more comfortable with a 26 gauge needle. But as Satyajit was pointing out, whenever there is a challenging situation and there is a tendency for the Rhexis to run off, it's a good idea to shift to. And as was also emphasized, there is no distortion of the main incision, and because of which the chamber tends to remain formed. I'm not quite happy with the way it's proceeding. Let's see. No, we have to do something. Yeah. Can you have the Rhexis scissors? Micro Rhexis scissors. सीधा देखिए अम्मा जी, सीधा देखिए. Saline of the cornea, little visco. Light देखिए.
This is real-time learning for all of us, and challenging situations can happen with anybody at any point of time, but how best you manage it and how best the experienced surgeons manage it is something we are seeing in real time, which is a good thing for us to take home.
Somehow not able to get a hold on that. 26 gauge needle. 26 gauge needle bit. These are excellent instruments, but not something I brought, so I'm not somehow comfortable with it. Let me see whether I can proceed with the. Spending a lot of time on Rhexis, I know, but I mean, it's time well spent.
True.
26 gauge needle. No, I use all these instruments interchangeably. It might look like a very novice surgeon operating, but I think...
No.
Whenever the 5cc syringe, saline.
So you still wouldn't want to use the main port for the Utrata forceps, sir?
No, I'm not using the, except for the, never using the main incision for the Utrata forceps. I'm always going through the side port. I'm seated temporarily. 26 gauge. सीधा लाइट देखिए उठाटा नहीं ये सीजर्स है मुझे ये चाहिए Wow, that was one of the longest Rhexis
Wonderful,
I've ever
sir.
made.
Wonderful. Wonderful. Very nice.
It's still a little smaller than what I would have wanted. In these kind of total cataracts, hydrodissection is not necessary at all. As you can see here, I'm able to rotate the
Very important take-home
nucleus.
message. Very important.
Biscuit. Okay, let's have the Phaco chopper. Now I'm going to be initially evacuating the cortical material. I use only longitudinal Phaco initially and then shift on to just torsional. So I have my Phaco chop settings initially. That's essentially because I want the irrigation parameters.
What is this, grade 5 cataract?
It's a white cataract with a fairly brown core.
Yeah.
And it was intumescent also, that's why all the bulging and
Correct.
the chamber was just about 2.6 millimeter. Can I have a sculpt?
Such a treat to see you operating.
Chop. I usually use an intraocular pressure of 30 only, which is a bottle height of 41. But I find the globe is too soft. Can you just increase it to 50?
So can we focus a little bit, sir?
Is it okay?
Perfect. So this is a direct chop.
This is a classical multi-level chopping. It's a very dense nucleus, and as you can see, I had to go at different levels.
Sir, in these kind of intumescent hypermature cataracts, even the zonules are a little compromised.
Absolutely.
So we have to be.
And I want that complete red glow. That tells me that the lens is completely divided. So all along I'm using only longitudinal phaco with the IP off, because I find that when you core the nucleus, we could discuss this later.
Can we center it a little bit?
Better?
Now, yes. Thank you.
You can see very little parameters used for even a dense cataract like this. It is not just the phaco power, but even the
Hold.
aspiration, irrigation, the bottle height, everything. I am quite happy with these 4 quadrants of viscoat, and I need some HPMC. Now I am going to do the quadrant evacuation. I use the dispersive viscoelastic to nicely coat the endothelium, and I'm going to be using HPMC in the center, because viscoat is something which is thermogenic, and sometimes it clogs the port and causes a wound burn. So I always like to operate in a lake of HPMC. This is some kind of a modified soft shell technique, quadrantamol. I am keeping it angulated posteriorly and keeping it as posteriorly as possible.
You have made such a nice division of all the 4 quadrants, but from 10 years earlier, I remember you had given advice to everybody that if you don't see the red glow at the back, use 2 dialers or 2 spatulas to separate it. You can come out, separate it, make 4 quadrants properly, see the red glow, and then advance towards phacoemulsification. Absolutely,
Satyajit. I'm so happy that you remember this. I mean, I'm sure you're doing it yourself. In the sense that, supposing this chop had not come through, that's the reason I make this trench. Sometimes extremely hard brown cataracts, whatever be your expertise or confidence, you are not able to get the Phaco Pro or the complete division. I do not hesitate to just, I'm going to fill up again with viscoat, because it's a fairly hard cataract. I'm using fair amount of power. I want viscoat enough.
That's such an important message to protect the endothelium again and again and again, and the posterior capsule.
And I would have just extended that central trench to make a complete division and use a 2 side port incisions, Sinski hooks, to essentially divide the nucleus. So basically, you should not provide with quadrant evacuation unless you have broken the backbone of the nucleus, and that's whenever you try doing that, then the whole surgery becomes a little messy. Oh my God. Oh, I have a PC rent. Oh. Hell. Can I have the vitrectomy? I don't know. This is not my day. I mean, vitrectomy. I don't know if in this. We have a problem. I think I'll have to shift my lens also. And I'm sorry about this. I don't know where. Everything seemed to be proceeding very smoothly.
You have done very nicely, sir. There's no problem. These things can
There is
happen
a
with
nucleus
anybody
fragment
anywhere.
inside also. But I'm going to go ahead and deal with the anterior segment. We can have ramstone estate also.
Dr. Sonali,
Yes, sir.
can you brief us on also on the next case of what is?
No, let's finish this case. I would
Yes,
definitely
sir,
like
yes,
to
sir,
show this. This is that, this is not going well, but it's important that you see cases which we don't do go well also.
Yes, sir. Yes, sir.
Can you identify a 3-piece lens which can go in? Fortunately, the patient doesn't have a, I need ramstone estate also. Fortunately, the patient is phakic in the other eye, and I'm aware of the fact that there is a small nucleus fragment that has gone in, but I'm going to still, I think there are competent vitreoretinal surgeons available here. So I'm going to go ahead and implant a lens, and I didn't see any surge or anything. I don't know how this.
Very surprising. Very surprising. I didn't see any time the posterior capsule coming up.
If these particles are there, it's always a good idea to do a 23 gauge, 25 gauge vitrectomy or a 27 gauge vitrectomy to remove these, and because otherwise the patient is disturbed by these floating particles for quite some time. Can I have aspiration? Aspiration. दोनों में irrigation aspiration लगा दीजिए. Sorry about shifting the entire scenario, but let's see what we can learn from this. Please. Got it. Now going to deal with the cortex.
Sir, would you want to put a IUL at
Sorry?
Would you want to put a IUL like we do in a IUL scaffold kind of a thing when situations like this happen?
Yeah, I'm going to do IUL scaffold only. No, it also depends on where you are operating. For example, I am confident that we have good vitreoretinal surgeons here.
True.
So there is a small nucleus fragment which has gone in. I'm sure that needs to be addressed. And normally, we would even shift the patient to the adjacent theatre where the vitreoretinal surgeon is operating and have that removed. But this can be done in the post-operative 1 week or so also.
It was a very, very small piece which went down. Very small piece. Yeah.
सीधा देखिए. हाँ, ट्राई कर चाहिए. You can see those vitreous strands still there. So never a good idea to drag on those. vitrectomy. Vitrectomy, yeah. Tricot दे दीजिए. Yeah. सीधा लाइट देखिए. Dilute किया. Ideally it should be, ठीक है, अभी vitrectomy दे दीजिए. Ideally it should be at least 1:3 dilution or 1:5 dilution. It seems to be. You came to see something else and you're seeing something else, but please feel free to ask questions.
Sir,
or
what
give
we are
inputs.
seeing is also very, very important, sir. It can happen with any one of us, sir. It's very important to see how you deal with it, and we'll have so much to learn from you.
सीधा लाइट देखिए माँ जी. It's always a good idea to confirm using tramstone estate that the entire vitreous strands are completely removed. And I always like to do that before creating a optic capture. Three-piece lens लिया ना आपने? You have taken a three-piece lens. Yeah, please load it. Whatever. Yeah, I mean, normally what you give for a. Yeah. So we'll enlarge the incision to 2.8 or 2.8 knife ले लीजिए.
Sir, sometimes this tramstone goes into the posterior cavity also.
Yeah. So sometimes not invariably it will go in, but I mean it's okay because it's going to only reduce the inflammation. It's a very transient raise in intraocular pressure. Sometimes it causes. That's not really an area of concern. But normally I use, thankfully it's not very often that we have to use it, visco, just visco, normal visco. It's diluted tramstone estate that is used. In this case I thought it was not. सीधा light देखिए माजी. I am filling the visco in the, this is HPMC, in the sulcus, in front of the capsular bag, because that's what I want to implant, where I want to implant the lens.
Sir, this HPMC will also have a tendency of going in the vitreous cavity, sir?
Yeah, we will remove it before creating an optic capture. You are right. Yeah, 2.8.
This looks like an absolutely wonderful surgery, sir.
That's nice of you to say that, Satyajit.
No, it's very nice, sir.
सीधा लाइट देखिए. Because the initial incision was 2.4, I'm just enlarging the incision. No, lens. सीधा फिर लोड कर दिया लेंस. This thing was not large enough. Visco. The globe is also very hypotonic, so because of that, knife दीजिए.
I think in these kind of cases, even the microscope plays a big role. The Luxor microscope, you can see everything so clearly with such a wonderful depth perception. that it eventually the management even becomes easier.
So that's absolutely true. You know, it has almost 6 times the red glow of a regular microscope. So even as you can see, even the lady is moving her eyes, you still have a very good red glow, and depth of focus is also very good, so that, you know, we can see the cornea, you can see the incisions, you can see the capsular Rhexis margin, and the viscoelastic in the vitreous cavity.
Yes, we can
So
see
all
that also. Sitting
yes.
here, we can see it so clearly. You must be
Yes.
seeing it
Yes.
even more clearly.
So I'm just waiting for the lens to be loaded. Basically, there have been occasions when faced with a situation like this, I have even placed a lens like a panoptics in the sulcus with a optic capture. But that's because, and then put these patients on steroids and for a significant length of time, for about steroid eye drops for 3 months with NSAIDs. It does work out, but in this case, I'm doing the more classical thing of Sinski hook.
So I think it turns out that a little smaller Rhexis was a blessing in disguise.
Correct, correct. That's right. You're absolutely right. See the light, dekhiye Maji? Very careful not to inject the lens into the vitreous cavity. Dialing hook. Jaldi, jaldi. I'm dialing the lens into the sulcus. Aye, irrigation aspiration. And now comes the important part where we have to, the vitrectomy part of this Centurion is also excellent. It gives up to 5,000 cuts, and you use you can use IA cut or cut IA mode. लाइट देखिए बस हो गया नहीं बस हो गया जी now that point aspect that you are talking about, to go behind and evacuate all the viscoelastic that's there.
What a wonderful surgery. Very nice, sir.
Can I have a Sinski hook now? Yeah. I'm going to create an optic capture. The way it's become a little triangular tells me that ovalization of the Rhexis tells me that's a good optic catcher that has been created.
Yes, sir.
And there is no need for the adjustment of the power of the lens saline. And it's important that, I hydrate the wounds before I come out, because if the chamber shallows, then this optic capture may be released.
It's a wonderful, wonderful demonstration of a masterly act of managing a difficult situation from word go on This case was difficult from Rhexis onward, and then
Saline.
yeah. So it wonderfully managed, sir. Must congratulate him. Everyone is like watching him with awe. Thank you for
See the light dekhiye.
learning this kind of situation in a real time is going to give a lot of insight to the learning surgeons as well as those who were learned surgeon.
I'm really sorry I didn't stick to the script, but then we had to make the best out of what we had.
Wonderful, sir. Wonderful, sir. So once you have finished, then we will have some more insight from you.
Yeah.
So one question is Dr. Ranjan is asking that once the PCR is there, so what should we do and what shouldn't we do?
No, once PCR is there, it's most important that we don't, go on with our irrigation aspiration and drag on the vitreous. It's extremely important that you deal with the, as you could see, the moment I saw that as far as the vitreous was not getting captured by my aspiration cannula, I went ahead and removed whatever cortical material was there, and there were some nucleus already there. Ideally, I should put some more viscode, create a sort of a scaffold there, and then go ahead with the removal of the nucleus. And most of the nucleus I could remove, fragments that I could remove. But the moment I saw that the vitreous strands were presenting, immediately I switched over to anterior vitrectomy and removed it quite completely. And then after that, once the cortex was also removed, I verified, though once you have a circular Rhexis rim, and you have a circular Rhexis rim, and you have a pupil is also circular, that means there are no vitreous strands. It's always a good idea to put in some diluted triamcinolone acetate and then do an adequate, make sure that there are no vitreous strands that are left over. And in case there is, as I am sure there are a couple of small nuclear fragments that went in, and this is definitely needs to be removed, and it cannot be left there because this is going to cause a rise in intraocular pressure, vitreous floaters, inflammation, etc. And with the master vitreous surgeons that are available here, they can do a sutureless vitrectomy with a 25 gauge itself because it's a very tiny fragment that went in. And once we do that, of course, the patient does not have the benefit of multifocality, but with the good optic capture, with the 3-piece lens in place, there's no change in the intraocular lens power that is needed. Based on only change has to be made based on the A constant that might differ. And once we do this, the patient is at least going to have reasonably good monofocal vision. And of course, follow-up of the retina with our retina vitreoretinal colleagues, at least for the next couple of years, is extremely important to make sure there are no problems. So not dragging on the vitreous is extremely important.
So the rent occurred during the removal of the last piece. I think there was no surge at all, so might be the one sharp edge of the nucleus has hit the posterior capsule, and that might be the reason. So what is your take on when we are taking this kind of hard nucleus, the last piece is to be removed, what precaution one should take?
No, I completely agree with you in the sense that, I was actually, I have had PCRs, but in this particular case, I was quite surprised. I was actually thinking of starting to discussing about the panoptics. I thought everything was under control. But, and as you also mentioned, as most of you saw, there was no surge. But I think that I don't believe that it was really the nucleus fragment which, it was not that sharp, and even for the endothelium can get damaged by the nucleus fragments repeatedly hitting there. But I don't think the PCR occurred there because of that. I think it's the surgeon's fault. Invariably, there must have been some movement forward of the posterior capsule which I missed, and then it happened in a fraction of a moment, changing the whole scenario.
I think that there must be some pre-existing posterior capsular dehiscence kind of thing.
There was no PPC, it was an intact capsule. I mean, I take the blame for it.
But you did a good job in the end.
So one question, like when we are advising premium IOLs for such grades of cataract, so should we counsel the patient before also that during surgery, if there is any problem, like we may not be able to put the lens, or is it like we should block these kind of patients all the time and then do, because it was a very hard cataract?
No, I completely agree with you. We have to forewarn these patients. There might be a change where the posterior polar cataract, extremely small pupil, subluxated cataracts, all these situations, hard cataract like this. We have to forewarn them that there might be a change in script. You might have to do something else. But just because it's a hard cataract, I think we need not, and it was a well-dilated pupil, the patient was just about 63, 64, denying the benefits of a good technology like a panoptic toric is not right. But once you have a problem like this, then naturally you have to deal with it, and the patient should have, I'm sure, was forewarned that there could be a change in plan.
Sir, at this point of time, I think it's easier said than done, but when you're removing the last piece, would IUL, putting an IUL first and then removing the last piece would have been a good idea, but as I said earlier, it's easier said than done now.
No, you're absolutely right, Satyajit, in the sense that, if it was just a clean-cut PCR and vitreous was not already presenting, I would have done this IOL scaffold and then placed the lens inside, maybe not even in the back, but in the sulcus, and then with that support could have retained the nucleus fragments. But once vitreous had started already coming out, then I did not want to do that, because in that case, that getting the nucleus, the lens, and everything get mixed up is quite a mess. I have done this IOL scaffold. Sometimes you get a nice punched out hole in the posterior capsule, and the vitreous face seems to be intact. In those cases, pushing in a little dispersive viscoelastic like viscoat so as to tamponade the hole that you create, then place the intraocular lens and go ahead with the rest of the surgery. It does very well. But as you could see in this was a very large rent. Just happened suddenly, and already vitreous was in the AC. In those cases, I think I would not doing an IOL scaffold, at least in my hands, doesn't work. I think that would cause a considerable traction on the vitreous base and may have other deleterious consequences.
So wonderful demonstration of a skill. Must say everyone to give a standing ovation to Ramamurthy sir. It was like playing on a Karachi pitch by Sachin Tendulkar or by Gavaskar. So wonderful demonstration of.
Thank you.